Welcome to the first ever episode of the Keep Them Guessing podcast. Okay, so one of the reasons I wanted to start my first episode on the topic of facelifts is because it's one of the specialties and subspecialties within aesthetic plastic surgery that drew me to the entire field in the first place. Facelifting, when I saw the results from Dr. Barton, Dr. Hamra, some of these giants in facelifting back in the day, literally looked like the grandmother and the granddaughter, not even the mother and the daughter. These transformations to me were wow factor. Rhinoplasty also is near and dear to my heart. I'm passionate about that as well, and that's why we're going to talk about my facelift approach a little bit first. But before that, I want to get into the history of facelifting. Many of you probably don't even know that facelifting began as early as the 1900s. Now, the first ever plastic surgery procedure was actually in 500 BC in India with Shushruta, where he did a forehead flap to reconstruct noses that have been cut off from sword fights and other trauma during warfare and little battles and quarrels they had. Back then, they fought with swords, not words on Instagram. So what we're going to talk about today, though, is the facelift technique that I prefer and most surgeons that do quality work prefer, which is to do some sort of treatment with the SMAS. The SMAS is this ever ethereal layer that people don't fully understand, but we're going to talk about the detailed anatomy. Now, facelifting began in the 1900s with Passot in France, where they started to just do these little ellipses of skin. If you look at this image right here, you know that that's not going to last. They didn't do what's called undermining, which means they didn't go under the layer they're going to lift. It's very similar to when you go lay in your hotel room and you can't get under the sheets, you can't pull it over, there's no movement. You have to release it from the foot of the bed to even get under. At least I have to. Otherwise, I feel like I'm cocooned and papoosed. I get claustrophobic. It's a huge nightmare. I have to call room service and all that. But with that release, think of those attachments at the end of the bed as almost the ligaments. Those ligament attachments are all over the face. You can see here where I have a fat pad myself, which I need probably Dr. Barton's help. Right here is attached. From here on, it's flat, but here it gets bubbly. There's attachments right here that are causing this to happen. It's the same reason you have a breast crease. It's the same reason some people have a very defined buttock crease under the buttock. These are all ligamentous attachments. It's also kind of what causes cellulite and all those issues. So if you release these like that hotel sheet, you can actually get movement and you can move the SMAS layer, which stands for superficial musculoaponeurotic system. It's a system and network of ligaments. This little fatty tissue looks a little bit like a cheese pizza, and there's muscle layers within that, which we're going to talk to Dr. Barton about in detail. So Passot did these little ellipses to pull just skin. That probably lasted, I would say, at the most, maybe like 2 to 3 months. There was a company a long time ago called Lifestyle Lift, which did something not different than that, almost a variation of that. Honestly, in the 2000s, doing something similar. That lasts about maybe a year if you're lucky, because they did go under the skin a little bit, but skin lifts don't work. You have to go to what the layer that counts as, which is a SMAS. So later on, let's fast forward. You had Mitz and Peroni, and then you had Yost and I think Levay, who studied the SMAS. Mitz and Peroni were in France. They were French surgeons that were understudies and fellows under Dr. Paul Tessier, who was a very well-known craniofacial surgeon, the father of craniofacial surgery, which is rearranging the skull, mostly in children, and doing all these really advanced Leforts, which Lefort is a French word as well. For some reason, the French like to move skulls and bones in the skull and head, but I don't know why. But Tessier was the master of that. He was the king of that. Mitz and Peroni were his fellows and discovered that SMAS layer. Skog, a Swedish surgeon, started to actually define the layer and go under it for his facelifts. And then you have people like Fritz Barton, Sam Hamra, and others back in the day, Bruce Cannell, who actually went under the layer and moved the SMAS in different directions. So let's get into the different types of facelifts. First, though, I want to talk, why are we even talking about this? Recently, you saw that certain celebrities in the limelight have gotten notoriety for possible facelift work. To be honest, we have a little bit of inside information, so I can't go in detail. I know exactly what they all had done for the most part, but I will tell you, don't always think that what someone had done is what they had done. That's why I personally don't like to comment on celebrities, but those that do often get it wrong. So A lot of the patients you think of at facelifts have only had upper blepharoplasties, a laser treatment, and maybe an endoscopic brow lift, which we'll talk about later, using a camera to lift the brow. Some people were on their third, fourth, fifth facelift. You don't know what work they had done prior. They might have just had a CO2 lift, which is a resurfacing that's very, very powerful on the skin that almost gives you a lift of the skin microscopically. Overall, looks like you had a facelift. So have they had high SMAS? Likely not. Have they had plication, SMASectomy? More likely. So let's get into those techniques and why it's important. So celebrities, definitely not new in Hollywood or in Los Angeles. Right now I'm in the heart of Beverly Hills in my own office building doing this podcast. My surgery center is 9 floors up. In that surgery center that I bought from a really classy, well-known surgeon, Peter Giacobazzi, a lot of famous people have been operated on by, I can't say by who, but there was one famous surgeon who was the first chief of plastic surgery at UCLA called, he was named Franklin Ashley, and some of the instruments actually put F. Ashley on them, Franklin Ashley. Phyllis Diller back in the day, Nancy Reagan possibly, a lot of people. So facelifting, facial rejuvenation goes way back in Hollywood. Marilyn Monroe had a chin implant done. She drove to Palm Springs, or was probably driven to Palm Springs, had a chin implant done. John Wayne, the big buff guy for cowboys, had an upper blepharoplasty. So Hollywood imagery and all of these icons, definitely not new to plastic surgery. There was a very famous picture of Zsa Zsa Gabor back in the day being wheeled out of this exact office building in the garage, black and white, on the cover of Inquirer, bound up with her face after having a facelift by the Williams brothers. So we're going to do an episode later of just Hollywood history and plastic surgery. That'll be really interesting. Let's get really quickly into the different types of facelifts, and then I'm going to bring on Dr. Barton. So we talked about the HIGH SMAS. I'm going to let Dr. Barton explain that more since he's the creator of it, and he was my mentor in Dallas at UT Southwestern, where I was fortunate to have trained under the legends in aesthetic plastic surgery, Dr. Barton, Dr. Bird, Dr. Rorick, Dr. Kenkel, Dr. Steve Bird. A lot of these well-known surgeons, Dr. Tebbets, were the who's who of plastic surgery at the time, and our Thursday conferences looked like ASAP's aesthetic surgery conference panels every Thursday. All these giants were there teaching me. I had Dr. Fritz Barton looking over my shoulder as I was doing his HIGH SMAS technique back in 2004, 5, and 6. So we're going to bring Dr. Barton on. But first, plication. That's the simplest, the most common one. You just take the SMAS, if you look at this illustration, and you're just folding it to tighten it together. So you're kind of grabbing, but you're not going under it. So it is not a sub-SMAS technique. Some people say it doesn't last as long. Some people like me say it tends to flatten the face because you can't go under and pull the SMAS wherever you want. You're limited, so you end up plicating or folding it on itself, and that can cause a bunching, flattening effect to the contours of the face. It is good to do in certain people, though, like young people who don't need all that power, and I still do it. It's very good to do for revisions or people who are on their third or fourth facelift. The other is SMASectomy. Whenever you say ectomy, like in cancer surgery or any surgery where you're removing tissue, ect means external in Latin, so you're removing and throwing it out. SMASectomy is like this illustration where you're cutting a strip of SMAS, bringing it together. One of the well-known surgeons who's in practice still, I believe, in New York City, Dan Baker, this was one of his top techniques, and this is a technique a lot of my mentors did, and I still do that one today. The third is sub-SMAS type, and the best of this, in my opinion, is HIGH SMAS because it goes really high, as you can see in this illustration. Above the zygoma, it allows you to actually grab this cheek fat, rotate this up so you don't need any fat grafting, if at all, or you can do some fat grafting in the tear trough, but you're not relying on ballooning the face with too much fat to get your lift. You're actually rotating in a very vertical vector. Vertical is so important in this technique to create what's called the HIGH SMAS, which we're going to have Dr. Barton talk about. Then there's other sub-SMAS variations where you can do more low SMAS, where you approach it way down here and go underneath. That's the most common deep plane. A little tired of hearing the term deep plane because so many people have variations of that. No one really knows what it is. But in general, if your surgeon is honest and they're actually doing a deep plane, that means they're going for a certain distance under this SMAS, approaching it usually here low. So this is what Dr. Barton, I, and people in Dallas back in the day would call a low SMAS. Those are great techniques. I still do that. In general, when I can, I try to go under the SMAS, and I do a sub-SMAS technique, either a low, deep plane with fat grafting if someone's young, or I do a high SMAS if they really need that power. In young patients, when you do a high SMAS and you combine it with an endoscopic brow lift, I'll tell you a little secret, it is unbelievable. And when you see these results like this, you cannot get that with going low, because your results are going to be low vibe. All right, so as I promised, my first guest is, he does not like praise and compliments. So, when we were in Dallas, we'd always do that too. He was a very humble man from Texas. Wait, are you originally from Texas?
I am originally, yes.
Okay. So Dr. Fritz Barton was the former chairman of UT Southwestern Dallas, where I was fortunate enough to train. At the time, his predecessor was none other than Dr. Rod J. Rorick, who I trained under as chairman there. I was fortunate enough, I left the program at the time by necessity, which was an amazing program, which I worked a lot with, as you know, Dr. Barton, Dr. Bahman Gairon over there, and then we went and worked with the giants and legends in all aspects of aesthetic plastic surgery. Honestly, it was like the mecca of plastic surgery back then in Dallas, UT Southwestern. So I want to welcome Dr. Fritz Barton. I'm going to ask him a little bit about his history of where he trained, et cetera. So welcome, Dr. Barton. Thank you so much for this. You're my first guest ever.
Oh, thanks. Good to see you, Ash.
Yeah, same here. I haven't actually spoken to him in a long time, well, in person. So, Dr. Barton, so you are well known and have been, and I consider you an icon in facelift surgery, and I think everyone agrees. I bring you up in our journal clubs all the time. I bring you up whenever I'm operating, and I have the fellows and residents in my operating room. First thing I would say is maybe you can talk about where you trained, where you came from. I know you were at NYU, and then go into why out of everything. I know you were good at a lot of things, and we're going to get to that at the end, because we get pigeonholed people try to say, oh, if he's a nose guy, he can't be a breast guy. And, Dallas taught me differently, and that's why I don't have a lot of friends out here. So what got you into facelifting specifically, and where was your training based?
Well, in my era, you did general surgery before you did plastic surgery, and but I always, while I enjoyed general surgery, I was drawn to the artistic side of surgery, which is what led me into plastic surgery. And after I was at Southwestern in general surgery, I went to NYU to do my plastic surgery. I did so. I picked NYU, and honestly, at that time, it was not a well-known academic program, but I picked it because it was one of the few places in the country that would actually openly teach cosmetic surgery. It was kind of a secret science at that point, and I figured with my general surgery background, I could, learn reconstruction, and they certainly had a good base there also. But it was the cosmetic side of the training that they provided that drew me there.
And was it Tom Reese was the chair?
Well, Tom Reese was the person who ran the cosmetic thing.
Got it.
Yes.
And Tom Reese, just so you guys know, is a legend.
John Converse was the chairman, but the person that ran who wrote the 7 volumes, but Tom Reese was really our mentor.
Yes. So just so you guys know, in my opinion, my humble opinion, I think the two best throughout history aesthetic plastic surgery training and plastic surgery training programs were NYU and Dallas. And of course, Dr. Barton, being the overachiever, went from one stellar program and ran the other. So NYU at the time, Tom Reese is a legend. Converse had I don't remember if it was 6 or 8 volumes, and then followed by McCarthy, and then later, I believe, Nelligan. But basically, it's the Converse scissors I use are, named after him in all my rhinoplasties. And Tom Reese at the time, I don't know if you know this, but I've spoken to some people, and supposedly he was clandestinely operating on a lot of royalty, and even operated on the Queen of Iran at the time. So he was a legend unto himself. And then, so what aspect of all of that would you say specifically facelifting? Because that's really where you developed your name.
Well, the reason I was drawn to faces was because they were the most artistically dangerous part of surgery. It's kind of like a moth to a flame. And at that era, facelift results were done as mainly just skin lifts, and they were inconsistent, and they tended to leave people sometimes stretched looking. So, I thought that there was an opportunity then to try to refine that and to learn how to do it in a way that would be reproducible.
Yes, phenomenal. And you definitely have achieved that. We may show some of your results from your textbook. If we do, here they are right here. Now, for the HIGH SMAS, we're going to get into SMAS really specifically. I gave the viewers and audience a little bit of history on, going from Passot to Mitz-Peroni, then Skoog. The SMAS layer, they already know what it is. I've shown it to them. And so what made you go into the HIGH SMAS? Why do you think HIGH SMAS is superior, if it is? And then I definitely want you to comment on the controversial twin study too.
Okay.
I knew that would get a chuckle.
Yeah, you're going to put me on the spot early here. Right? I view myself as having made a partial contribution to the SMAS facelift. It certainly wasn't just my idea. And I was influenced by Skoog's book in 1974 while I was in residency. And then a surgeon in Dallas that few people know, named Mark Lemon, actually went to visit Skoog and thought it was a good idea to pursue that. And Sam Hamra came back to Dallas and joined him. And so together they started trying to figure out how to do a Skoog facelift. Skoog was a brilliant guy and his idea was good, but he didn't live long enough to really develop the technique. He realized it would be a good idea, but he never really developed it into a facelift that had anterior power. Mm-hmm. And so the next people that helped with that were Hammer was, and we were good friends. And so I was watching his work. But when I watched that part of it, which was called the deep plane at the time, it was mainly focused around the jowl and the neck.
What year was that? Because I sorry to interrupt you, but everybody talks about deep plane. So I want people to know that, a lot of things that are old become targeted and marketed as new. What year was deep plane quoted?
I believe that Lemon and Hamra wrote that article in 1980. And that was the beginning of it before that. And yes. So then I came back to Dallas in 76 and started doing, the one nice thing about being at the university is I had an unlimited amount of fresh cadaver material to do dissection studies. And so I spent really 10 years doing dissection studies, trying to figure out how to do it. And I was trying to figure out how to get the upper part of the malar subcutaneous fatty mass, as I call it, to move with the lower part. Because in the early phases, the SMAS was used along the jowl, and then the upper part was just a skin lift, still like the history had been.
Yes. Well, I think, one thing important that you said is anterior. Some people don't know what that means. Some do. Anterior means front. So what Dr. Barton was saying is a lot of the treatments were behind the neck, pulling the neck, doing good posterior work behind the ear, but people were not really getting a little cheek mobility. They weren't able to lift the cheek, which a lot of people cheat with fat grafting now. But to be able to rotate and grab this cheek tissue in a meaningful long-term way and go up, I believe is the power of your technique. Now, would you say that your HIGH SMAS technique, which here's an illustration of what it looks like, that HIGH SMAS technique, because you're above the zygoma and your purchase is so good, you're able to be above the thing you're mobilizing. Now, how advanced would you say that is? In other words, if someone's training on facelifts and they want to do plication versus a HIGH SMAS, what level, if a plication is a level 3, 4 in facelifting, what would you say a HIGH SMAS is to stay out of trouble?
You mean in terms of difficulty?
Difficulty learning, difficulty executing. And you can be honest here.
Yeah, it is a complicated technique to some degree. One of the reasons I didn't publish my own series for 10 years was because I was working in a residency and fellowship training situation. And I don't believe that any technique is good if only a few people in the world can do it. So what I was trying to do was work out a safe sequence whereby residents, and I ended up taking every resident and fellow at Southwestern through this technique when I was there. Often it was the first facelift they ever did. But what I spent time doing was trying to figure out a dissection sequence that would be safe so that anybody could do it. because if any good surgeon can't do a technique, then the technique's not any good.
That's good, but well, that's true. But the whole good surgeon thing, you know, I don't know. I think the training I had, I think it perplexes people sometimes because I do revision rhinoplasties they're on their fifth one with rib graft. I do HIGH SMAS. I also do fat transfer of the buttock, and I'm on the advisory board basically to help that become a safe surgery. And I do breast augmentation the way that I learned from John Tebbets in 25 minutes with no bleeding. So people have a hard time believing that it's possible to, you know, the whole jack of trades, master of none. I think, honestly, my pedigree coming from Dallas and my passion for this, I think negates that, but I think sometimes it's true. But I would say it's hard to reproduce the techniques. It's very challenging because you can go teach a Formula One, you know, it's hard to teach maybe a Lexus Mercedes mechanic to become a Formula One, even though they're great mechanics and engineers to fix a Formula One racing car. I feel like it's advanced. Reproducibility really has to do, I think, with innate talent. You know, it's not everyone had the good fortune to be doing a bilateral, both sides, HIGH SMAS and having you over their shoulder like I did while you were working on your book and then in the corner and then coming and looking over my shoulder. If you don't have that in your background, I think it is an advanced technique. I don't know if someone can watch videos and reproduce it. It's going to take some time. What would you say to that?
Well, no, I think that's true. I'm not minimizing the care and detail and time it takes to learn it. But I do think if someone is willing to spend the time and effort and be well trained, that anyone who's willing to do that and is a competent surgeon could learn to. The truth is, it's a lot of trouble. And most, you know, in this day and age, the whole idea is to do things as fast with as least trouble and as least recovery as possible. Well, those things are, you know, they'll pretty much negate quality in my mind.
Okay. Very fair. Very fair. What's your thoughts on this whole deep plane thing? I know you work still with some, and you hang out with some of the younger folk who are in their 5th, 10th year, et cetera, of practice. And I'm sure you've heard the whole deep plane craze and everyone calling everything deep plane. We talked about it earlier, but that's essentially a low SMAS where you enter a little bit lower. You go under the SMAS to whatever degree the surgeon does. But if they're going here and going about 2 centimeters and not really recruiting tissue and pulling with the right vertical vector, a deep plane is just a fancy SMASectomy plication. But what do you think about deep plane low SMAS if it's done correctly?
Well, I think that's what Hamra and you know originally did, and it was a step forward, but it was, you know, it didn't address the upper malar area adequately, and it still doesn't. And I think that's the reason that there's so much malar fat grafting is because the low SMAS doesn't relocate the subcutaneous fat up over the zygoma the way, which was the whole point of, if I had anything to contribute to the technique, it was to define the release of the investing fascia over the mimetic muscles and the zygomatic major without getting too complicated with the facial muscles, to release it so that it could go vertical. Yes. Instead of just going sort of horizontal or diagonally back.
This way.
The key to the whole thing is vertical.
Yes, exactly. And a lot of people talk about a vertical facelift, which I love. If you go under the SMAS enough, do vertical. And Dr. Barton's HIGH SMAS technique, where you're above zygoma, is this bone up here, our cheekbone that extends out, becomes thinned out. If you're above that, you're above the cheek. And when you're above something, you can lift it. You can't lift something if you're below it. That's very common sense. Now, this fat grafting craze with not being able to recruit tissue, do deep plane, and compensating by fat grafting, what would you say to that if someone knows how to make the fat survive? I know you feel like it's a little hocus pocus and like almost like how you used to tell us suturing moonbeams and things that don't really work. What's your thoughts on fat grafting? Do you feel like we're at a point now where we've kind of learned how to make it survive and it's okay? To the face?
I don't have any problem with fat grafting, and I actually did a moderate amount of it in my practice. I do think there are some patients who lose facial fat who do have deficient facial volume of fat, and you can't there's nothing to relocate adequately in that situation. My whole goal was, there are also patients who have too much facial fat. Nobody talks about those patients at meetings, about the patient. I mean, you don't fat grafting someone who already has a full face.
Not good.
That doesn't make a lot of sense.
They call that pillow face if it's filler. It's just
so
over.
I think that, I think if the fat's adequate, the thing to do is relocate it. If they're deficient, then I think the only solution is to add fat grafting. Now, we can debate what percentage of fat predictably lives, but there certainly is a role for it. I don't deny that.
Perhaps maybe the nasolabial fold, piriform aperture area, the apices, like areas like that. But what you believe in and what I believe in is not compensating for lift and the power of a lift with fat, but just contouring and finessing it. It's kind of like the whipped cream or cherry on top. It's not the cake itself.
I think the point is that if they have the normal amount of facial fat, that the first step is to relocate it. Then if there are areas of deficiency, that's a different question. But I think what we see a lot is that people graft rather than relocate.
Exactly. Okay. Now let's switch gears a little bit and go towards what we discussed earlier that I think is so important right now. With AI, that's a whole nother topic. I mean, I think in 2 to 5 years, we're going to have a lot of trouble with even knowing what surgeons being honest about the results, what's going on. And plastic surgery is just a little esoteric, tiny little part of the problem that's going to be happening. I mean, they could essentially start wars based on AI. There's no bomb that even was ever dropped. I mean, the consequences are going to be unparalleled. But when it comes to plastic surgery, aesthetic plastic surgery, self-image, I have 2 daughters that are impressionable. They're on Instagram, they're on TikTok, they're on social media. Even though they know what I do, like they come to me and ask me, is this real? What is this? And I look and it's a filter, making someone look great, ironing out their face as if they had a phenol peel, and then they didn't. And then 5 layers of makeup, professional hair, great lighting. So it's not even really achievable. I think expectations have become a lot harder. When I was in my first 5 years coming out of Dallas, I mean, I was able to, everybody was pretty realistic, no complaints. Everybody was pretty happy. And I think my results have gotten better, but complaints have gone up. And I think it's because there's a lot of unrealistic expectation. What would you tell someone if you're in practice right now and they came to you and showed you an image like that, and you can, what are we supposed to do now with unrealistic expectations? Because I feel like it's getting harder and harder for patients to become happy from the work we do, and they don't really know how much work and training we put into it.
Yeah, I think setting expectations is the hardest thing in aesthetic surgery in general, and particularly in faces. And I do think that, the manipulation of images, which started with Photoshop years ago and now has gone on to AI and other things, that makes it very difficult. But that just makes the initial consultation much more important. And I think you have to reach a point with the patient that you can feel or hopefully communicate realistic expectations. And more importantly, if you have a patient who doesn't have real expectations, the answer is don't operate on them. Exactly. Because you are destined to failure. You can't please someone who's unrealistic. But honestly, I was fortunate maybe in the era that I practiced, because there were a few of those patients, certainly. But the majority of people, if you were straightforward with them, the majority of people were reasonable. But I don't, maybe at this point in time, that percentage-wise is different.
Yeah, I think it's different. Even when I was a resident, what we looked at as the icons and images were still in magazines. They were celebrities. They weren't your neighbor down the street or your best friend who happened to have a following on social media. Now everybody wants a voice. Everybody wants a podcast. Look what I'm doing. I never thought I'd be doing a podcast. If you told me in 2007 when I graduated from Dallas, you're going to be doing a podcast one day and you're going to be on your phone posting everything you do as much as you can. To be honest, I wish social media didn't exist. It's a problem in many areas, and the technology is too advanced for human emotion regulation to catch up with, because not all humans are evolved enough to handle the consequences. I think we have to find that balance. Now, when it comes to facelift results, we've seen some in the media lately where people think some godly result was achieved, whereas really it was filters, makeup, possibly a smastectomy with a bleph and CO2 laser, or maybe an endoscopic brow lift bleph and a CO2 laser, erbium laser. Certainly, that's unrealistic expectations, but I do think that the skincare should be discussed. I think if I showed that result, I would say patient had professional makeup and she had a CO2 laser. And we both know how important lasers are, and I know you've transitioned a little from peels to lasers. What would you like to see, and how happy are you with the current laser technology in the skincare? Because skincare, I tell people it's like a couture suit, like a Tom Ford suit that's wrinkled, has a coffee stain, you spilled some wine on it. It's not going to look like a good suit. Or a non-steam cleaned couture dress. Skincare and laser treatments are so important to the result of a facelift and facial rejuvenation. What's your go-to, and what are your thoughts on lasers?
Well, before we do that, let me, just as an aside, walk back to one other thing we were talking about earlier, and that is the best way for patients to evaluate your result is to see a patient you've done. And so when you sort of start out, and if you have a patient who you get a good result on, then her friends are going to see her, that not social media. And that to me is the most valid and the best way to do it. Is that the results that you actually show people live, or that you don't show them, but that they show each other, to me, is the best marketing you can possibly have.
Yes,
And
I
it's
agree.
valid because there's nothing but real life there. Now, back to the skincare thing, I do think that it's true that no matter how good the structure of your face is, if the surface doesn't look good, then it kind of dampens the benefit, whether that be in dull reflection of light, because you need exfoliation or removal of old dead cells with skin, whether it's pigment aberrations, which are common, especially with older patients. So I do think, and I've been enthusiastic about that for years, I do think that the quality of the skin is not only, but it's equally important, but it is a major factor not to be ignored in an overall result.
Wholeheartedly agree. I still love the way you guys taught me TCA peeling too, and rubbing hard, the sponge being soaked versus damp, the perioral area rubbing hard with a rough gauze, 2x2, all that. I still do that today, but we have a lot of lasers in our armamentarium and our toolbox here, and it's rare that I do a facelift and don't bring that out. Even if the patient doesn't want to pay for the add-on of a laser, I'll sometimes, maybe I shouldn't announce this publicly for financial reasons, but sometimes I'll just be like, you know what, we're gonna do it for you because you gotta have that. What do you see? I'm gonna put you a little bit on the spot before we wrap up here. So I won't go too in depth into the twin study, just for the background, so all the viewers know. There was a study done with different types of techniques, and the conclusion was it didn't matter with the right surgeon and right technique match. What technique you chose, the facelift result was still good. Now, I, as you know, with my training, can do plication, smastectomy, high SMAS, low SMAS, deep plane, all the work, different platismplasties. I'm still not fully into the glands yet. But what is your thought? Is there a role for some of the quote unquote lesser complicated surgeries, maybe in a revision or someone younger, like a plication, smastectomy? And what would you generally want to tell us about that facelift twin study and long-term results and techniques?
You put me a little bit of a corner, because you have to realize that when I was at NYU, my senior resident was a year ahead of me, was Sherelle Aston, and Dan Baker was my junior resident.
Yeah.
So they're still my good friends, and they're both superb surgeons.
Yes.
Now I disagree with the twin study, and I disagree with the concept. One of the things, the NYU group never really bought into the high SMAS or the SMAS type thing, and I think they even published a study that showed that it didn't make a difference. But my answer to that is it depends on how you do it. So I think it makes a huge difference what technique you use. But that's my opinion, and everybody doesn't have to do it the same way. Now the question is there a role for a lesser procedure? And I did do some lesser procedures in, but a particular situation. There's some patients who had just a very thick, heavy, fatty jowl and very poor tissue, so that I didn't get an adequate suspension of the fat that I wanted. And I would say that out of maybe I did about 1,500 face HIGH SMASs in my career, and I would say, and I kept a list of these people actually, and there were about 15 of them, okay, over that period of time. And I went back on those people and then did a application technique, you know, rather than trying to redo a SMAS when I knew that the quality of their SMAS was not good anyway. So I do think there's a role for that. In my hands, it was a role for secondary failures, not for primary procedures.
Mm-hmm.
The one last thing I would say is that how you do application technique matters, I think, because if you do, and again, I have great respect for Dan Baker, but I'm going to disagree with his technique. When you do that technique horizontal, and actually Alfred did that way back in the 60s.
Mm-hmm.
What you're doing at that oblique thing is you're pulling the zygomatic fat down as you pull the jowl fat up.
Mm-hmm.
So
you're flattening.
You could in fact fix one thing and break another with that technique. I think if you want to do it then the deal that Tennard and Limperley did, from Belgium, where they did their loop and did all the vertical technique and suspension high, that to me, if you're going to do a plication or a suture suspension without doing a dissection, to me that makes probably more sense. But again, as I say, I only did it in a small number of people who were revisions.
Yeah, so what Dr. Barton's talking about is, we talked about it earlier and I showed you the graphic. We'll show it to you again. Here it is, where when you fold the tissue, if you're folding parallel to the nasolabial fold and you're doing a little bit of the vector or angle of your pull, if you're pulling it and you're not going vertical with your plication still, you might be pulling the cheek down, pulling this up, bunching things, destroying a little bit or flattening out the contour. Correct. I know some very good plication surgeons, or, as you know, one of my mentors, Rod Rourke, I think does a lot of stacking, and I wrote papers with him, and he does mastectomy, and he does phenomenal, beautiful work, and he's stacking, he's doing mastectomies, he's altering techniques in everybody. I do think I still like to try to go into the SMAS. Now, I did have a patient recently where I did a high SMAS on one side. When I went to the other side, she had previous trauma to her left side of her face. There was no SMAS. I don't think I've ever seen that in my life. One side of her face had almost no SMAS because I think all the vessels and nerves and investiture were just destroyed from the previous trauma. But I do think what Dr. Barton's saying is if you're going to do these other techniques, they should be executed in your hands the way you know how best to do them, and you can get adequate and sometimes very good results. Last thing I'll say is thank you so much, first of all, for joining me on my first podcast. We'll probably put out 2 versions of this. One will be kind of a lay person's version, and then one will be for our plastic surgeons around the world and facial plastic surgeons around the world that are passionate like we are about facial rejuvenation and facelifting. I do want to end it with one quick thought, though, and that is, do you think that the whole filler, Botox, those shortcuts, they're definitely overdone out here? I mean, I have dinner sometimes, I look over and they call it pillow face, where the lymphatics are just clogged, destroyed. Hyaluronic gel is everywhere. There's Botox. The facial muscles aren't moving. Is there a role at all now, do you think, still to do some filler judiciously in Botox until someone's ready for a facelift? And then should we dissolve all of it away before we do a facelift?
Well, we do in my little clinic that I still run. We do fillers, but we do it very cautiously. I think a concept that's been promoted that's wrong is that fillers lift. And, fillers fill, they push out, but they don't lift against gravity. And so I really do believe that descent, there is deflation sometimes, but descent is a presence of aging. And just blowing a size, a size a face up to size 10 for a size 5 body doesn't make sense to me. So we all see those patients. So it still gets down to judgment. There's a role for all of these things, but again, it's all about art and judgment and using them to the degree that's appropriate, and not trying to do something with fillers that only surgery will do.
Mhm. Very, very well said. I just want to remind you guys, the person we have in front of us here talking about this, to me, is one of my heroes in facelifting. And I was lucky enough to train under a lot of my heroes before I even came to Dallas. So I want to thank you again, Dr. Barton. But this is basically like talking about facelifts with Dr. Barton is like talking about, basketball with the late Kobe Bryant and Magic Johnson and these Larry Bird, or, talking about painting with oil with Salvador Dali, Renoir, and Picasso. So I truly appreciate you, Dr. Barton. Thank you so, so much. I'm going to bid you farewell, but before, I want you to meet someone who trained at NYU, who I got as my colleague here, and I'm sure he'd want to say hi to you. He's from NYU, trained there, and then he also is joined me. He was my fellow 2 years ago. He joined my practice, and it took me a while to find someone who had some humility but could also walk the talk. As you guys taught me in Dallas, a lot of people talk the talk, but they can't walk the talk. And in Texas, you can't be doing that. And I'm sure right now we don't want to keep you from dinner. You're going to go have a big Texas porterhouse or something. But Neil, come on in and just say hi real quick. This is Dr. Neil Varanis.
Hi, Dr. Barton.
Hi, Neil. How are you? Good to meet you.
I think you trained also some of my colleagues. There was an NYU Dallas connection for the last 5-6 years. I think there was Ira Savetsky, Justin Bellamy, Michael Kyoto. They all came through the Dallas Fellowship and through you. And I've heard
Well,
a
we
lot of
still,
great things about you.
it's a generation far enough that I didn't have direct contact with a lot of them. But on the other hand, there's sort of a fraternity, that around NYU, and I still have fond feelings for it. And I still talk to Dan and Sherelle fairly often, and get back when I can.
Yeah.
But congratulations on joining Ash. He's a quality surgeon, and he's a good person. And you'll learn, excuse me, you'll learn a lot from him. So listen to what he has to say.
Absolutely
Thanks.
incredible surgeon, even better mentor. Thank you.
Thanks, Dr. Barton. I appreciate you. Go get that porterhouse, some extra mash for me.
All
Thank you.
right.
Take
Thank you.
care.
You bet.
All right.
Bye-bye.
Bye. So you guys had the good fortune and the luck, honestly, to hear from a true icon and a legend in the industry of aesthetic plastic surgery, Dr. Fritz Barton. Once again, thank you again, Dr. Barton. He really laid it all out. He's a straight shooter from New York and Texas, but originally from Texas, and there are definitely straight shooters there. And I could tell you, it reaffirmed everything we talked about, and it's so important to know that there's not one way to do something, but sometimes there is a better way. So if you don't want to be under the SMAS as a surgeon, that's fine, but something with the SMAS layer has to be done for it to work. And the most important thing I would say to take away from this right now, and this landscape of social media and everything, is, we have these different techniques. We have SMAS plication, which may not have the power it needs to for a lot of people, but it works for some. We have SMASectomy, and these in the right hands with the right patient do phenomenal. And then we have sub-SMAS procedures like this, where you're going under the SMAS, whether you go low in a deep plane, and everyone calls it deep plane. There's whole conferences called deep plane. And then you have the high SMAS, which to me is kind of the extended sub-SMAS, extended deep plane, where you're going really high above here and capturing the malar fat pad and all this and lifting it up and getting that power vertical. And even when you do a SMASectomy or SMAS plication, if you angle it this way and you take it out in this fashion, you're going very vertical and you get correction of the jowl, you get that snatch jawline. We didn't address the neck or talk about the neck a lot, but I could tell you, since I trained with Dr. Barton, I know what he does. Very tight corset, tight from here to the hyoid, and then a little looser below. And in some patients who need it, you can transect and help the bands and go across and do a release and excision of the platysma muscle that comes from here up. Here's a graphic of what the platysma muscle looks like. The tightening you do here is so important because that's going to help cinch all this up. And then you can do deep neck work. You can go under the platysma, remove a little bit of the digastric muscle and remove some of that, shave it or remove all of the front part, anterior part of that. And you can go even further, more extensively, and shave off or excise a portion of the submandibular, kind of the saliva spit gland that lives here, and some people where it hangs. There's so many ways to do this, but in general, in facelifting, my philosophy is go deep or go home. And same with rhinoplasty. With rhinoplasty, if you don't go deep, you're going to end up going home because you're not going to fix breathing. The septum is deep. The bones are very deep. If you want to correct deviation, bad breathing, nasal airway obstructions, you got to go deep there too. And in life, we're going to talk about so much in this podcast, and we're going to go deep in life, biohacking, wellness. None of this matters if you're not doing well in your health, if you are exhausted and you're aging rapidly. You can't receive or perform a facelift the right way. So until next time, thank you so much.